Hello everyone, my name is Lourdes and I work in the cardiac ward in one of the hospitals here in Brisbane. Today I'll be presenting to you a case scenario involving a patient who developed a pneumothorax following a thoracentesis or pleural tap procedure. This case highlights the importance of early detection of acute deterioration, understanding of physiological changes, and the prompt clinical response to the situation for early treatment or management. A 74-year-old patient whom I referred to as John, not his real name, was admitted to the hospital for a workup of severe mitral valve regurgitation. He was initially presented with short of breath and dyspnea. His past medical history includes rheumatic heart disease, severe MR, hypertension, and dyslipidemia. These are managed on a low dose of beta blocker, a furosemide, aspirin, and atorvastatin. His initial investigation showed a preserved LV function with 58% ejection fraction and confirmed a significant volume overload. His furosemide was increased to IV 40 mg twice daily. His chest X-ray and CT chest revealed a large right-sided pleural effusion, in which he underwent a thoracentesis, draining 1.5 liters of fluids in 20 minutes. Approximately 8 hours later, John reported a pleuritic chest pain worsens when breathing, accompanied with lightheadedness and breathlessness. John's is hypotensive and tachycardic with a blood pressure of 86/50, with MAP of 62 millimeters of mercury, and heart rate was 112 beats per minute. Respiratory rate was 26 and oxygen saturation of 91% on room air. The medical team was immediately notified due to these concerns. An urgent clinical reassessment was performed. His skin was observed to be pale, cool, and clammy. Auscultation revealed reduced breath sounds on the right side. John remained alert and orientated with GC score of 15/15. We also performed an ECG and commenced him on telemetry monitoring. ECG showed right axis deviation and a low voltage of QRS complex. This is an important indication of a cardiopulmonary interaction. Upon detection of John's clinical deterioration, a series of prompt and coordinated actions were initiated to ensure his safety and stabilization. While waiting for the medical team, we initiated oxygen 4 liters per minute via nasal prongs, aiming to maintain saturation above 94%. IV cannula was inserted to ensure access for fluid resuscitation. Blood test was sent to assist diagnostic clarity and ensure readiness for further intervention. Cardiac enzymes were negative, indicating his chest pain was non-cardiac origin, and 5 milligrams of indone was given for his chest pain. The arterial blood gas was also taken, and it indicates John has slight respiratory acidosis due to impaired gas exchange, with a less oxygen inspired as seen in the partial pressure of oxygen, and more carbon dioxide is being retained as evident in the increased partial pressure of carbon dioxide. Upon review by the registrar, furosemide was temporarily ceased. 250 ml of IV fluids was administered under close monitoring, given the risk of pulmonary edema due to his underlying severe MR. His vital signs were monitored frequently and showing gradual improvements. A bedside chest X-ray was arranged urgently and it showed a moderate right-sided pneumothorax. John was transferred to ICU for needle aspiration. He actually recovered well post-procedure. He was monitored overnight in ICU and was transferred back to the ward the next day for ongoing workup of his valvular disease. John's case scenario is a clear illustration of acute deterioration after having thoracentesis. Thoracentesis is an invasive respiratory procedure to remove fluid from the pleural spaces. The needle is introduced in between the ribs and into the pleural cavity, applying negative pressure to the plunger to detect intravascular placement as seen in this photo. With this procedure, complications such as pneumothorax can happen, particularly in patients with underlying cardiac background such as severe MR and pulmonary congestion, where respiratory reserve may already been compromised. In this second photo, it showed a right side collapsed lung compared to the normal left side of the lung. Physiologically, The large needle used in thoracentesis can directly puncture the visceral pleura, and air can leak into the pleural space, where it pushes the lung. As a result, the lung collapses. The air occupying the pleural space creates a positive pressure in that area, hence the lungs cannot expand during breathing, and this leads to alveolar hypoventilation. As a result, there are some areas of the lung that may be perfused but not ventilated, or there is a mismatch in the ventilation-perfusion process leading to low oxygen uptake, resulting in hypoxemia because the body cannot compensate fast enough. The oxygen saturation falls, as seen in John's saturation of 91%, which is mildly hypoxic. In this situation, the body's compensatory mechanism responded with tachycardia, but perfusion was still low. This is seen in his low blood pressure and lightheadedness symptom. Other mechanism of his hypotension is that the air in the pleural space can compress the vena cava, reducing preload, resulting in a low cardiac output and low blood pressure. The experience of looking after a patient with a complicated condition was a valuable opportunity for reflection in my nursing practice. Early recognition of a patient deterioration was helpful. The clinical intuition and vital signs checks, extensive assessment, and a quick nursing action prevented John's further deterioration, and the quick escalation to the medical team and timely communication were effective. However, there were more areas for improvements. Firstly, a thorough pre-procedural risk assessment in consideration to his comorbidities may have highlighted the potential for post-thoracentesis complication, especially in a cardiac compromised patient. Secondly, advocating for the patient for a slower and more controlled drainage process could have lessened the risk of pneumothorax. The nurse will closely monitor the patient tolerance to fluid removal during the procedure and communicate with the doctor about signs of instability. And finally, this case reinforced the need for implementing an enhanced post-procedure monitoring protocol, such as increased frequency of observation for 24 hours post for those high-risk patients like John. In summary, a 74-year-old patient was admitted with severe MR for MVR workup. He underwent a thoracentesis for his pleural effusion, draining 1.5 fluids. He then was acutely deteriorated after 8 hours post-procedure, and immediate nursing actions were initiated, including escalation to the medical team, administering oxygen 4 liters per minute via nasal prong, performing ECG to rule out ischemic cause of chest pain, administering analgesia for the pain. For further immediate treatment were initiated as per registrar's review, including ceasing the furosemide and administering fluids, bolus for low blood pressure, and increasing the frequency of observations were attended. An urgent chest X-ray was revealed pneumothorax, and a needle aspiration was done in ICU with advanced monitoring. He recovered well post-procedure and came back to the ward to continue workup for MVR. In conclusion, this case highlights the importance of clinical vigilance, early recognition of symptoms, immediate action, and advocate for timely investigation and interventions, and continuous reflection to improve patient safety. It was a valuable learning experience in recognizing clinical deterioration and understanding its physiological changes for appropriate intervention and a positive outcome. Thank you for watching my presentation, and here are my references. Have a great day!